Bronchiectasis is the permanent, irreversible dilation of the bronchi, resulting from a secondary structural failure of the airway. This anatomical deformation represents the physical manifestation of a dysregulated host defense cycle. Once the muscular and elastic components of the bronchial wall are destroyed, describing a self-perpetuating loop of impaired clearance, bacterial colonization, and tissue damage. Because the lung architecture is being actively digested by this feedback loop, clinical management focuses on mapping and interrupting the vortex before the damage becomes terminal. Interrupting the vortex requires identifying the exact stage and anatomical location of the morphological destruction. High-resolution computed tomography, or HRCT, provides the anatomical mapping necessary to stage the severity of the disease. 2025 protocols differentiate treatment based on the spread of the disease. Diffuse pathology scattered across multiple lobes triggers a multimodal medical track, while strictly localized disease triggers a surgical track. The specific radiologic phenotype of the patient determines whether the primary intervention involves pharmacological suppression or physical resection. A healthy lung continuously clears microscopic debris using the mucociliary escalator. This clearance relies on the CFTR channel, the cystic fibrosis transmembrane conductance regulator. This protein channel maintains an isotonic mucus layer by extruding chloride ions, drawing sodium and water to create a balanced fluid layer. Beneath this, dynein arms consume ATP to walk along microtubules, powering the cilia's rhythmic whipping motion. Systemic genetic defects can paralyze this entire system. CTFTR mutations dehydrate the airway and produce thick, viscous mucus, while conditions like primary ciliary dyskinesia physically disable the dynein arms. Localized etiologies can also create physical roadblocks, compressed by enlarged lymph nodes, blocked by foreign bodies, or deformed by post-infectious scarring. Whether the initial failure is genetic, immunological, or mechanical, the physiological outcome is identical. The mucociliary escalator halts, and the airway becomes a stagnant reservoir. This mucus stasis provides a microenvironment for chronic bacterial colonization. Pathogens like Pseudomonas aeruginosa or non-tuberculous mycobacteria take hold. The presence of these chronic colonizers triggers an exaggerated immune response, characterized by severe neutrophilic inflammation. Localized macrophages detect the bacteria and secrete signaling proteins, specifically interleukin-8 and tumor necrosis factor alpha. These cytokines relentlessly recruit neutrophils into the airway. Once they arrive in the airway, these hyperactive neutrophils release back chemical payload, unleashing potent tissue-destroying proteases like elastase and metalloproteinases. These enzymes digest the host's structural proteins, breaking down the muscular and cartilaginous architecture of the bronchial wall. The airway sags outward, widening permanently. This flaccid airway traps even more mucus, locking the patient into an accelerating cycle of structural destruction. In bronchiectasis, the host's own immune system dismantles the lung from the inside out. Physicians translate the microscopic destruction of the vortex into macroscopic diagnostic criteria using high-resolution CT scans. Physicians identify the disease by measuring the bronchoarterial ratio. In bronchiectasis, the airway-to-artery ratio exceeds 1.0 in adults, or 0.8 in pediatric populations. This creates the signet ring sign on a cross-sectional scan. The dilated, air-filled bronchus forms the band of the ring, while the smaller pulmonary artery sits beside it like the jewel. A secondary radiologic confirmation of structural failure is the lack of distal airway tapering. The diseased bronchi fail to narrow as they extend toward the periphery of the lung.
The morphological progression of the disease is visible on imaging. It begins as cylindrical bronchiectasis, appearing longitudinally as parallel, thickened walls known as tramlines. As the vortex continues, the walls deform further into varicoid bronchiectasis, resembling varicose veins. The final stage is saccular or cystic bronchiectasis, where large blebs of destroyed tissue inflate with pus. Correctly identifying the spatial distribution of these phenotypes, whether diffuse across both lungs or strictly localized to one area, is the prerequisite for assigning the patient to a medical or surgical track. For patients with diffuse disease, the strategy relies on placing pharmacological and mechanical roadblocks to suppress the vortex. The first cornerstone attacks mucus stasis. Patients use mechanical positive expiratory pressure devices paired with nebulized 7% hypertonic saline to osmotically draw water into the airway and thin the mucus. Pediatric guidelines support hypertonic saline, but caution against routine mucolytic agents or inhaled corticosteroids, unless bronchial hyperreactivity is proven. The second cornerstone is inflammation attenuation, often achieved through long-term macrolides, like azithromycin. Macrolides are prescribed at sub-antimicrobial doses for their immunomodulatory properties, specifically to downregulate cytokine production and suppress neutrophil activity in the airway. The third cornerstone is infection control. This involves culture-directed oral or inhaled antimicrobials tailored to suppress heavy colonizers, specifically targeting Pseudomonas aeruginosa. Medical management successfully slows the velocity of the vortex to preserve the patient's remaining lung function. Surgical resection is the only way to physically remove an unsalvageable vortex entirely. The absolute prerequisite for surgical consideration is that the disease must be strictly localized to a single lobe or segment. Diffuse disease is a contraindication for resection. A primary trigger for surgical evaluation is life-threatening hemoptysis. This is driven by the ulceration of hypertrophied bronchial arteries, and surgery is indicated when less invasive endovascular embolization fails to stop the bleeding. Under 2025 clinical mandates, proceeding to surgery requires a formal assessment by a multidisciplinary team, or MDT. This team consists of a bronchiectasis physician, a thoracic surgeon, and a specialized anesthetist. This chart compares post-operative pulmonary complication rates based on lung function. FEV1, or forced expiratory volume in 1 second, is a measure of airway obstruction. Patients with a preoperative FEV1 of 50% or less of their predicted value face a 3.27-fold increase in complication rates. To mitigate risks, patients undergo a 4 to 6 week prehabilitation phase of targeted antibiotic washouts and intense airway clearance to achieve a perfectly dry operative field. When surgery proceeds, video-assisted thoracoscopic surgery, or VATS, is the preferred approach over open thoracotomy, owing to its lower morbidity rates. Modern thoracic surgery for bronchiectasis serves as a targeted, physiologically optimized intervention against localized tissue destruction. The future of medical management looks towards disabling the cellular mechanism of structural destruction. Emerging phase trials, such as the ASPEN trial for brensocatib, are investigating reversible DPP-4 inhibitors. DPP-4 is an enzyme involved in immune regulation and inflammatory signaling. These drugs are designed to prevent the activation of neutrophil serine proteases, like elastase, breaking the exact link between neutrophilic inflammation and tissue digestion. Bronchiectasis is a permanent structural airway failure driven by a self-perpetuating host defense loop. Whether utilizing hypertonic saline, performing a robotic resection, or deploying next-generation protease inhibitors, the goal remains the same. The physician must identify the phenotype on HRCT, interrupt the vicious vortex, and protect the architecture of the lung.